Hello students, watch this video till the end for all the dermatology AIIMS November 2019 questions which will be discussed, and even timestamps will be provided for the benefit of you to not waste your time. And this video is going to be very important from INSET, NEET and also FMGE point of view. So watch this video till the end for your benefit. I have even included timestamps, but definitely as you are all very much well versed, you can also watch this at 2x speed so that you can save the time. So myself Dr. Maddineni Srinivas Kumar, certified dermatologist from India, discussing derma related videos, and in this series we are going to see all the AIIMS questions of the previous 3 years. So if you wish for a PDF version of this presentation, just type PDF in the comment section below, and if you want more of these sessions on a daily basis, just type hashtag DrMSD in the comment section below. And these are the May 2019 AIIMS questions which were discussed in the previous day's video. You can check out the link. I will provide it in the iCard here, and also I will keep that link in the description below and also in the first comment. And you can join my Telegram group for all these latest updates. So if you have any doubt related to dermatology in the YouTube, just type your dermatology related query. After you type DrMSD, most likely you will get answer in the form of the questions with a brief explanation. So this is my YouTube channel. If you are not yet subscribed to this, please do subscribe and also hit that bell icon for all the latest notification. And now let us start without any further ado. This is the question which was asked in the November 2019. A psoriatic patient showed good response to oral steroids, but on stopping these drugs, he developed pustular lesions all over the body as shown in the image. And in the image you are able to see multiple pustular lesions which are present in a generalized fashion involving the entire body, and they can also join together to form lakes of pus appearance. So that is also one of the possibilities. When all these pustules join together, we call it as lakes of pustules or lakes of pus. So this is the question, and if you have marked the answer as option C, pustular psoriasis, then awesome, you are absolutely right. So why is this pustular psoriasis? And in fact, pustular psoriasis along with erythrodermic psoriasis, so these two are very serious complications which can be seen in a psoriatic patient. And most important clue which points out towards this pustular psoriasis in this case is the usage of the oral steroids. See, basically psoriasis is an inflammatory condition. So you might think that yes, steroids, which are anti-inflammatory drugs, they are going to reduce the lesions of the psoriasis patients. Yes, you are absolutely right, but the problem comes when the patient stops these medications. So when psoriasis patients is started on oral steroids, then definitely there should be a monitoring on these patients so that they are not going to stop these medications abruptly. And these steroids, if at all they are started, they should be tapered very slowly. Otherwise, what will happen if these medications are stopped abruptly, then the inflammatory component is going to grow out of proportion, and the patients are going to land up into two possible life-threatening complications of psoriasis. One is pustular psoriasis and the other one is erythrodermic psoriasis. So these are the two types of psoriasis which you must remember, erythrodermic psoriasis. So these are the complications, and you might be wondering why is it not option A, Staphylococcus aureus infection. Maybe the patients of psoriasis, because they are started on steroids, they are having immunosuppression, they are developed immunosuppression, and so they are having secondary bacterial infection. Maybe you might have thought that, but please remember, if option A has to be the answer, the examiner would have mentioned that the oral steroids, after the patient was started, immediately he developed these kind of pustules in a generalized fashion all over the body. But the examiner is telling that steroids were started, and at that time of the steroid usage there was good response, and after stopping these medications the patient developed pustular lesions all over the body. So it is not Staphylococcus aureus infection. And acute generalized exanthematous pustulosis, this the patients are going to develop due to drug intake. So there was no history of any drugs apart from the steroids. Steroids are in fact used in AGEP. It is called as acute generalized exanthematous pustulosis. So this option is also ruled out. And the last option, subcorneal pustular dermatosis, which is in short called as SCPD, it is actually also called as Sneddon-Wilkinson syndrome, and this is associated with certain malignancies, multiple myeloma or IgA gammopathy. So this is also not the answer. So you must also remember that psoriasis can be triggered by certain drugs. So drug-induced psoriasis can also a possibility, and the drugs you can remember with this simple mnemonic PLABS. So P stands for painkillers, which are NSAIDs, non-steroidal anti-inflammatory medications. L stands for lithium. L stands for lithium. A stands for antimicrobials, like for example hydroxychloroquine. B here is antihypertensives, beta blockers, and yes, the most important one, systemic steroids. And the first four of them, the usage of these medications is going to produce psoriasis, whereas the last one, the withdrawal of the systemic steroids, is going to cause the patient to land up into pustular psoriasis. So these are the pustules which can coalesce together to form these kind of lakes of pus. Okay, now let us not go into these all details. Okay, this I have already told you. And this is the next question. Patient presents with oral lesions along with flaccid blisters which are present over the scalp, face, trunk and extremity. So you can see almost the entire body is involved. And what are the lesions which are present? Flaccid blisters. Blisters in the sense, it simply means fluid filled lesions which can be vesicles or bullae. And how are these? These are flaccid. So the opposite for flaccid is tense. You must remember these two terms are very important in vesiculobullous disorders. So now you are asked for what is the diagnosis, and if you look at the options, you can see option A says pemphigus vulgaris and option D says pemphigus foliaceus. And yes, in this particular picture, when flaccid blisters are present, you must think about intraepidermal blistering disorders. Intraepidermal blistering disorders. And among the given options, dermatitis herpetiformis and bullous pemphigoid, they are subepidermal blistering disorders, so we can easily rule them out. And in fact, dermatitis herpetiformis, the patients are going to have itching or present over the body and papillovesicles which are present over the extensor aspect of their body. And in bullous pemphigoid, the patients are going to have tense bullae and tense vesicles. So these two are ruled out. And now the next important clue which is given in the question is that patient is having oral lesions along with the lesions over the body. So now if you look at option A and D, you must remember that yes, pemphigus vulgaris is the condition where the patients are going to have oral lesions, whereas in pemphigus foliaceus, mucosal involvement is absent. Mucosa is spared in pemphigus foliaceus. So the answer here is going to be pemphigus vulgaris. So pemphigus vulgaris, the patients are going to present most of the times with initial involvement of the buccal mucosa in the form of erosions, and later on the patients are going to develop lesions over the body in the form of these flaccid blisters. And my question to all of you, what is the desmoglein which is going to produce these mucosal erosions? So type your answer in the comment section below. There are two important types of desmogleins, 1 and desmoglein 3. So among this, which of the following is involved in mucosal pemphigus vulgaris? Please type down your answer in the below comment section. And yes, in the skin, these blisters, they are going to rupture very easily. Why? Because they are very superficial blisters, and later on they are going to form into erosions, and these erosions are very slow healing, and they are going to easily extend onto the surrounding normal looking skin, and there is absolutely no tendency to heal. And just remember this fact from the past, the pemphigus vulgaris patients who were treated earlier, some 30-40 years back, and when the steroid usage was not so much in pemphigus vulgaris patients. The case fatality of this pemphigus vulgaris used to be 100%. All those who are diagnosed as pemphigus vulgaris, they used to succumb and they used to die. But after, thanks to the steroids usage, now the fatality has reduced drastically. And here you can see this is a patient of pemphigus vulgaris, having vesicles and also bullae, and you can see here the flaccid bullae is present, and these are going to form erosions after the roof of the blister is ruptured. And yes, as you can see here, the lesion is only and only going to extend onto the normal looking skin, so much so that the patient will succumb and finally die due to the secondary bacterial infection, which can be a complication of these open wounds. And a quick, recap, or we can say summary in pemphigus vulgaris and bullous pemphigoid, what are the features? So in pemphigus vulgaris, remember that it is an intraepidermal blistering disorder, so very, very important. Acantholysis is present in pemphigus vulgaris, whereas in the case of bullous pemphigoid, it is a subepidermal blistering disorder, so there will not be any acantholytic cells, no acantholytic cells. And you must also remember that in pemphigus vulgaris, the stratum basal cells, they are connected to the underlying dermis with the help of hemidesmosomes, which are not going to have any autoantibodies in pemphigus vulgaris. So there is going to be a row of tombstone appearance which can be seen. So these are the buzzwords, very, very important. And because acantholysis is present in pemphigus group of disorders, Nikolsky sign will be positive, and bullous pemphigoid Nikolsky sign will be negative. Why? Because there is no acantholysis in bullous pemphigoid. And these are some of the differences. Yes, flaccid blisters in the case of pemphigus vulgaris, whereas in the case of bullous pemphigoid, tense bullae will be seen. And here you can see desmoglein 3 and desmoglein 1 are the antigens against which antibodies are present, whereas in bullous pemphigoid, it is bullous pemphigoid antigen 1 and BPAG2 which will have antibodies produced. And pemphigus vulgaris, as I have already told you, it is absolutely fatal condition if left untreated, whereas in the case of bullous pemphigoid, there is a possibility of even spontaneous resolution. So this is the next question, very, very straightforward. You can say one-liner question. ABCD is used for skin malignancy. Which skin malignancy? So the simple answer for this question is malignant melanoma. So in malignant melanoma, remember these ABCDE. A stands for asymmetry. So if you observe this lesion on the left hand side, these are benign lesions, whereas these lesions which are present on the right side, these are malignant lesions. And in the benign lesions, the symmetry is going to be perfectly preserved, whereas in the case of malignant lesions, that is malignant melanoma, the lesions are going to be asymmetrical. So A here is asymmetry, B stands for the border. So in the case of benign lesions, the border will be very, very regular, whereas in the case of malignant lesions, the borders will be very irregular. So color, if you observe a benign lesion, the color of the entire lesion is going to be homogeneous, whereas in the case of malignant lesion, the color is going to be variable. At certain places there will be hyperpigmentation, and certain other places there is going to be relatively less hyperpigmentation. And in the case of diameter, just remember that in malignant lesion, the diameter is going to be of the lesion is going to be more than 6 millimeters. And evolution, the size, shape and texture, the color, all of these in malignant lesions, they are going to evolve very, very rapidly. Okay, that's it. Just remember that these points in malignant melanoma. So now let us move on to the next question. And my question for all of you is, what is the most common type of the malignant melanoma? Type in your answer in the comment section below. Very, very important topic, malignant melanoma. And all of the following present with morbilliform rashes except, so you need to identify the odd man out. So first of all, understand that morbilliform, it itself means measles like rash. So option A is ruled out. Why? Because we have to identify the odd man out here, in which morbilliform rashes are not seen. And just remember that even in dengue and rubella, so basically in viral infections, you can remember that morbilliform rashes are present. But last option, which is shingles, it is also produced by a virus, varicella zoster virus, no doubt, but in singles, the patients are not going to have morbilliform rashes. Basically, morbilliform rash simply means maculopapular rash which is present in a generalized fashion all over the body, as you can see in this child. Whereas in the case of shingles, which is also called as herpes zoster, the patients are going to have multiple erythematous based painful vesicular lesions which are going to be present in a particular dermatome in a unilateral fashion. So this is the classical description of herpes zoster, and this is a classical picture of herpes zoster. So the patients are going to have multiple grouped vesicles. So multiple grouped vesicles will be present, as you can see here. Fluid filled vesicles are present, and the base is going to be red, that is erythematous base will be present, and these lesions will follow, they will follow a dermatome very strictly, and they are unilateral all the time. So on one side the patients are going to have these classical lesions, and most important, the patients are going to have a symptom of pain. So painful lesions will be present. So this is the classical description of herpes zoster lesions. And yes, now coming to the next question. So what is the true association among the given options? Yes, and you must remember that yes, option C, psoriasis and metabolic syndrome, these two are the true association. So now let us understand psoriasis. Why? Because this is very important. As you can see in the first question, we have seen pustular psoriasis. Again, now you are able to see psoriasis. Another question is asked. So basically, psoriasis is an autoinflammatory condition which will not only involve just the skin, it can also involve the joints. If you remember, psoriatic arthropathy is produced. Not only that, it can involve systems. It can also involve systems like, for example, cardiovascular system can also be involved. So just remember that psoriasis is not just inflammation of the skin, but it is a systemic inflammatory condition. It is a systemic inflammatory condition, and the most important system which you must remember is cardiovascular system. Cardiovascular system, because of the involvement of which the patients are going to have hyperlipidemia. Hyperlipidemia, the triglyceride levels will be elevated and the HDL cholesterol levels will be reduced. The patients can also develop hypertension. Hypertension can be present, and also they can have a central obesity. So if you observe all these features put together, we can call it as metabolic syndrome, which was what was asked in this particular question. So as you can see, the hyperlipidemia will be present, low HDL cholesterol, and there is going to be obesity which is going to be seen, and these patients are going to have elevated sugar levels and elevated blood pressure. So all these are features of psoriasis. And now we'll move on to the next question, treatment of paucibacillary leprosy. And mind you, in this question, the answer depends upon what the examiner actually asking. So for example, treatment of paucibacillary leprosy according to National Leprosy Eradication Program or according to World Health Organization. Both of them are slightly different. I will show you what is the difference, but before going to that, if the examiner just asks you like this, then what you have to take is the latest guidelines of World Health Organization are to be taken into consideration, and you have to answer accordingly. So you must remember that for paucibacillary leprosy, the treatment is going to be used for a period of 6 months. So option A and option C are ruled out, and you can see 2 drugs for 6 months or 3 drugs for 6 months. So just remember that if the question simply asks treatment of paucibacillary leprosy, then always answer according to World Health Organization. And yes, WHO Health Organization says that in PV leprosy patients also 3 drugs should be used for a period of 6 months. So now let us look at the treatment modality. So multi-drug therapy is the plan which we are using for leprosy patients, and if it is paucibacillary leprosy, then we have to use rifampicin 600 mg once in a month supervised dosage, and dapsone 100 mg supervised dose on day 1, followed by 27 days in which the patient can take the dapsone without any supervision. and also the clofazimine has to be added. So according to the latest World Health Organization guidelines, even clofazimine has to be added even for postbacillary patients, and the dosage is very simple to remember. So just half the dosages of rifampicin and dapsone, you are going to get the answer for the dosage of clofazimine. So 600, half of 600 is 300 mg, which the patient should take once in a month supervised dosage, and half of 100 mg of dapsone dose, that is 50 mg daily of clofazimine has to be taken. And the only difference between postbacillary and multibacillary is the drugs are going to be the same. The only thing which is different is the duration, 6 months here, and it is 12 months in the case of multibacillary leprosy. So these are the guidelines, as you can see here. National Leprosy Eradication Program, the recommendation is postbacillary patients 2 drugs, that is rifampicin and dapsone, for 6 months, whereas multibacillary rifampicin dapsone along with the clofazimine will be added, the duration is 12 months, whereas World Health Organization 2017 guidelines state that the drugs should be 3 in number, whereas the duration is in postbacillary 6 months and in multibacillary 12 months. So I have repeated it n number of times. This is very important new concept which the AIIMS people will be mad after to again and again ask. So please make a note of this. A child, now let's move on to the next question. A child came with complaints of hair loss in a patchy form over the scalp associated with easy pluckability of the hair. Physical exam reveals black spots which are present on the patch of hair loss. So what are the points which you will understand in the question? So first thing is, you must highlight that yes, the patient is a child and there is a patchy hair loss which is present, and there are some black spots which are seen. So with all these clues, you must be in a position to diagnose that yes, this child is having tinea capitis. And yes, the answer for this question is griseofulvin. So let us slowly see what is the diagnosis, how is the diagnosis, and what are the medications which can be used in these patients of tinea capitis. So tinea capitis, I hope you all know that it is divided into 2 types, non-inflammatory and inflammatory type of tinea capitis. And in the non-inflammatory variety and also inflammatory, in both this, the hair loss will be there, that is alopecia will be there, but the only difference is non-inflammatory, the patients are going to have non-scarring alopecia, that is, it is a temporary form of hair loss, whereas in the inflammatory variety, the hair loss is going to be a permanent hair loss, that is a scarring alopecia. And the important examples which you must remember are chorion and fevers. Whereas the non-inflammatory variety tinea capitis, we have 2 types, it is black dot, and the other one is a grey patch. So just remember, the black dot variety, over the scalp we can see small black dots. And what is the basic reason for this is, simple way to remember is, the black dot variety, the tinea capitis, it is due to the endothrix variety of funguses. What does the endothrix mean is, because the spores can invade into the hair follicle and they are going to produce damage to the hair follicles. The hair will break and these broken hair shafts can be visible to the naked eye over the patch of the hair loss in these children. That is the reason why this is also called as black dot variety. And this is a simple thing which you must remember, that the dermatophytes are 3 of them: trichophyton, microsporum and epidermophyton. And you must also remember that the possible structures which can be involved or infected are skin, hair and nails, and trichophyton. In trichophyton, all the 3 structures, skin, hair and nail, are going to be involved. And remember, these dermatophytes, they love keratin, and yes, keratin is present in skin, hair and nails. Okay, so trichophyton, so all the 3 structures will be involved. And since we are reading dermatology, skin is going to be infected by all these, that is trichophyton, microsporum and epidermophyton. So now just remember these 2 points, that M microsporum, M is very close to N nails. So this will think sorry for the nails, and so it will spare the nails. Why? Because it is a neighbor, so let us leave the nails. So M is close to N, so it will feel that both of them are neighbors and it will not involve nails. So likewise, epidermophyton, E and H, they are close to each other alphabetically. So this will think that I should not involve hair. So hair is paired in epidermophyton. So just remember that epidermophyton is not going to cause tinea capitis. Okay. And in the treatment, drug of choice for tinea capitis overall is griseofulvin. Treatment of choice for tinea capitis is griseofulvin overall. Whereas if the examiner mentions that the causative fungus is trichophyton, in such case the treatment of choice is going to be T for trichophyton and T for terbinafine. And if the examiner says the causative organism is microsporum, then in such case the answer is going to be griseofulvin. More than even itraconazole can be used. So this is what you have to answer if this is asked in the exam. So I hope this video was very helpful. If you felt this was helpful, please do hit that like button, friends. And if you are not yet a member of my Telegram group, the link is there in the description. Just check out that link, click that link, and you can join in my Telegram group. And just hit that red subscribe button so that it will turn out to become white, which is very peaceful, which is going to remind of the peace. So instead of the red subscribe, just turn it into white peace. So people say, taste the success once, tongue wants more. This was the dialogue of Kapil Dev. So it was kept in the movie 83. So analogous to that, if you are nearby to the exam, just grant test. Remember, grant test help you to get the first taste of the success. So do not miss writing the grant test. Also, most importantly, do review all the grant tests, the mistakes which you are making in the grant test, and always you should have that positive attitude that I can do it, I can achieve the rank which I am going to get it. You are deserving candidate to get whatever seat you want to get. And yes, you can follow me on Instagram, the links are there in the description here below, and write down your name in the comment section and take this pledge. At the end of this class, you are going to be responsible for your success, and you are going to get the seat of your choice from the state of your choice, and most importantly the branch. You are going to get a very good rank so that you can select whatever branch you want to join in. So that's it in this session, friends. Do share this video among your friends in various social media platforms, and also thank you so much for watching this video till this point. Myself, Dr. Maddineni Srinivas. Do subscribe to my YouTube channel and also hit that bell icon, friends. Do like this video if you really enjoyed this. Happy learning, not just dermatology, all other subjects also. Sarvam Sri Krishnarpanam, Sarve Jana Sukhino Bhavantu.